Our first presentation is going to be from Dr. Sarah Jane Commander. As I mentioned, she is a senior vascular fellow in the Vascular Surgery Fellowship Program at the University of Florida. And so, Dr. Commander, thank you very much for presenting, and the floor is yours.
The presentation that I have today is on carotid patch infections, and the case is one of our own. We have a 62-year-old male who presented with right internal carotid artery occlusion and symptomatic left carotid artery stenosis. His symptoms were notable for left amaurosis fugax over the past few months, with complete vision loss of the left eye that resolved after minutes. He's medically comorbid with COPD, hypertension, diabetes, CKD, CAD, and was a prior smoker. His anticoagulation status is notable for Plavix. His carotid duplex showed internal carotid velocities over 200 with end diastolic velocity of 84, suggestive of a 50 to 79% stenosis. He underwent a left carotid endarterectomy on September 19th. He had some mild neck swelling in the incision, but overall he recovered uneventfully and was discharged on postoperative day 1. Unfortunately, he represented to the emergency room a month later with cellulitis and swelling, spontaneous red purulent drainage from his incision. His labs were notable for a white count of 14, and a CT was performed notable for abscess in the surgical bed. We performed vein mapping, which demonstrated a 6 millimeter right GSV, which was suitable for use for carotid bypass. Here is his CTA demonstrating that he has an abscess, and I'm sorry, I don't think I can point. I'll let it play again. There's an abscess, if you look right here, in his surgical bed. He was taken to the operating room the subsequent day for excision of patch and carotid, washout of the surgical bed, ligation of the external carotid artery, and common carotid to internal carotid artery bypass with right great saphenous vein. We performed this over a shunt as his contralateral side was occluded. Unfortunately, I don't have an intraoperative photo, but the technique is shown in an article using PTFE, where you preload the conduit on the shunt prior to insertion of the shunt. Then you sew the distal anastomosis followed by most of the proximal, remove the shunt, and complete the few sutures left. This reduces cerebral ischemia time to less than a minute. After this time, we did an additional washout and performed an SCM flap with partial skin closure. Due to neck swelling, he remained intubated until postoperative day 2 and was extubated without incident. He had no cranial nerve deficits and passed a swallow evaluation. He recovered uneventfully and was discharged on postoperative day 4 on aspirin and Plavix, as well as cefepime and vancomycin for 6 weeks via a PICC line for mixed skin flora. He has since followed up to our clinic twice and is doing very well without signs of infection. He's completed his antibiotics and postoperative duplexes without residual fluid collections and a patent bypass. His neck incision has healed by secondary intention pretty nicely. Few management strategies are proposed for carotid patch infection, and mainly consider the use of autologous vein as a patch or interposition bypass. This is most often performed with great saphenous vein or deep femoral vein. At our institution, we prefer a vein size of at least 6 millimeters for proper hemodynamic matching to the common carotid artery. An alternative approach, which we can discuss, is described in Europe called the endovac hybrid approach. And I'll go into detail of these in just a second. At our institution, we published CEA patch infection experience from 2002 to 2017 on 29 patients and the reconstructive options. The median time to reintervention was 15 months, with staph and strep the most common organisms. Interposition with femoral bypass vein was used in 83% of patients. Saphenous vein was used in 14%, and femoral vein patch was used in 3% of patients. 1 patient died in the postoperative period and 1 had a stroke. Cranial nerve injury was the most common complication at 28%. However, all were fortunately transient. This is the endovac method described by Shihab et al. In the European Journal of Vascular Surgery. 9 patients underwent this method for infected carotid patch. Also at the time, there was a pseudoaneurysm and blowout. They used a transfemoral approach to the external carotid artery embolization and common to internal carotid artery stenting with a covered stent graft. Interestingly, then they made a standard CEA incision and debrided the patch to expose the stent. Then they put a wound vac directly onto the stent and allowed the tissue to heal by secondary intention. They put their patients on 7 months of antibiotics, and they reported that none of the 9 patients experienced reinfection. The purpose of this technique is to reduce cranial nerve injury as less exposure is needed, as no clamping is needed. We can discuss whether we would, use this approach or not, but it is an alternate method that is out there. Gallery here. The incidence of carotid patch infection in CEA is about 0.5 to 1%. The presentation is usually drainage of the incision or swelling in the neck, and management, at least at our institution, is most often with explantive patch and vein bypass. Thank you very much. I'll take any questions.
Thank you, Dr. Commander. That was outstanding. And it's a great question and sort of I think it's a challenging case that any practicing vascular surgeon has is probably faced at one point or another, either created on their own. Certainly, I've had a few in my own career, or you've been referred this problem. And there's, as you've sort of highlighted in a very erudite way, there's a number of different strategies that could be employed. And so we would open this up for any questions. I don't know if Dr. Patel has seen anything on the Q&A that's come up. Otherwise, I certainly have a number of questions, or if Dr. Patel, if you had any questions to sort of open the floor.
Great presentation. I think we clearly all see this, and I'll get to Dr. Fieser's question here, posted here shortly. I definitely wanted to ask some questions myself, and some of it mirrors what Dr. Fieser is asking. So I'll throw them out and then please answer them as you will. Number one, you showed a duplex ultrasonography. Was there any preoperative CTA imaging to thus help guide surgical planning, such as potentially doing a TCAR for the patient? Secondly, these carotid infections, I know you mentioned the patient had a hematoma. They shouldn't happen, and unfortunately they do, and they can become such difficult things to treat, because a lot of times you see them come back again, bleed again and again. And so the second question I would have is, sometimes when I go in, I redo the patched with vein, and in this case you guys use interposition saphenous vein. Do you see that has less of a risk of recurrent blowout?
Okay, thank you for your questions. For the first, we routinely use duplex, and if there were any considerations for a high lesion or any kind of discrepancy with what we were seeing, excessive calcium or such, then we would proceed with a CT. So we don't routinely necessarily get both at our institution, although I know some attendings do. We did not consider him for a TCAR because he was seen to be of good operative risk. And then I agree, the hematoma can be difficult. There's another paper that I had looked at determining if the type of patch, a synthetic patch, would make a difference in not an infection. And hematoma was actually cited as the only significant difference between a Dacron patch and a bovine pericardial patch. And that hematoma formation leads to more infections. So I do agree that kind of managing your hematoma is of paramount importance. And then in terms of vein versus bypass versus patch, we do favor bypass here. Oftentimes in these infected fields, the carotid artery we think is too fragile and delicate to work with. It has also been infected. And so we debride the carotid into healthy carotid, and then we perform the bypass then. We do occasionally replace it with vein. However, we do favor the bypass approach due to the severe infections that we have seen.
Thank you. A couple more. I'll let Dr. Scully get his in. So 2 questions from the audience. Number one, what was the original patch material you used? And then secondly, were intraoperative cultures obtained? And if so, what did they grow? And is the patient on any long-term antibiotics?
Thanks for that. We used Dacron patch in this case. And then for cultures, it grew mixed skin flora. He was on antibiotics via PICC line for 6 weeks, and then we discontinued that. And he's done well since.
Thank you.
Staff absence.
Yeah, and so I would just basically echo on some of those comments. I think the key is obviously it's an all autogenous reconstruction. Whether or not you can patch or versus interposition, I think it's a judgment call. Obviously, it depends on the degree of arteritis that you run into, and you have to sort of make judgments on the field. Obviously, in our experience, we've patched. That was in our experience that Dr. Commander presented, but the overwhelming majority of the cases that we've done at the institution historically have, after debridement, we've been left with less than a 50% of the wall. And so we've favored the bypass, but recognize patching is a reasonable strategy as long as you feel like you have sufficient wall remaining after the debridement and that you've adequately debrided all of that surrounding tissue. But the key is just an all autogenous reconstruction. We have not embraced the endovac strategy. I'm familiar with a senior author from Uppsala who wrote that, and I've had discussions with that person. As Dr. Commander said, that is in the literature, and it's good to be aware of alternative techniques, certainly, and to pay some attention to that. But with 9 cases and no long-term follow-up, it'd be hard to sort of adopt that early. I would say we would be a late adopter. We would have to see a lot more data over time.
Yeah.
If there's no more questions, go ahead. I'm sorry.
So the only thing I think I might use is if it was indeed a carotid blowout, it
Sure.
would be a good way to temporize. However, I would take out the stent and do the bypass after I had obtained hemostatic control.
Certainly for otolaryngology, for ENT disasters with malignancies and radiated neck, we have used temporizing stent grafts as a palliative strategy, knowing that that may not work long term, but it's a reasonable bridge therapy. But for reasonable risk patients, particularly for carotid patch infections that we've initiated or that we've gotten in transfer, we have not used stenting. Stenting's been used anecdotally as a bridge only in a severe hemorrhage case. And we've rarely ever had to ligate somebody who's had a carotid blowout.
Yeah.
You know.
One other question was, do you believe in routine draining, especially in thicker necks where we could potentially reduce hematomas and maybe subsequent infections with the drain? Does anybody routinely drain?
Our group is split on that. We have routine drainers and routine non-drainers. So I think at least at UF, the jury is out on that. This one was drained. That's correct.
I'm the same way in my practice. If it's oozy, I'll drain it. If it's not, I won't. One last question for myself. The patient had a contralateral carotid occlusion. In my practice, I typically like to get CT imaging more so because I may not always trust the person doing the duplex in our community hospitals. And so TCAR was not used in this case, and that's clearly dealer's choice. What was your neuromonitoring for that case? Do you technically do EEG, routinely shunt? I know you shunted in the second case.
We always shunt. So we only have very rudimentary, we don't have any EEG.
Oximeter.
Yeah, we do an oximeter, but it's not exactly reliable, I'd say.
All shown.
But everyone is shunted here.
EEG, if you want it, you can get it.
Yeah.
Yeah, but we
Well, thank you guys. Great case.